Any questions from last time? Nothing at all. So you guys know the good pathway for managing asthma?
Yeah.
It's like a good starter medication. Almost everyone should be getting on.
Saba.
Saba, what's a Saba? Which is? Albuterol, right? They didn't want to use albuterol, they want to use an alternative. What could they use? Zopanax, which is? Levalbuterol, right? So against that enantiomer, some people feel there's less side effects, but I don't really believe it. But it has to do with the studies that weren't actually looking at comparative doses or equivalent doses. So for instance, 2.5 milligrams of levalbuterol is equivalent to how many milligrams of albuterol? Based off the fact, it's an enantiomer, it would be double, be the equivalent albuterol dose. But they're doing like 5 milligrams of albuterol to like 1.25 of Zopanax. So of course you get less side effects because there's less drug you're using there. But I digress. Already off to a bad start. Let's continue on talking about COPD, right? So we're going to see a lot of similar medications here used in COPD as in asthma, but the order of selection is going to be a little different. Certainly, what is sort of the pathophys of COPD? Chronic inflammation, destruction of the tissue, right? So whereas asthma tend to be fully reversible, how about in this case? Not so much, right? So, and again, patients have a lot of reserve, meaning that they will be causing this sort of progressive destruction over time, may not be manifesting a lot of symptoms until there's pretty significant effects going on here. So again, we're going to see that the drug selection is going to be a little different in terms of things that are important for them. Certainly, are they a bigger risk for, say, infections? Potentially, yes, because again, they don't have, normally, we said that the lungs are nice and sterile. They have those nice ciliated cells that kind of get all the gunk out of the lungs. What happens when you're chronically smoking over a long period of time? Burn up all those cells, right? They get rid of those, and so certainly infection's a concern. So what type of vaccine should they be getting? Influenza, certainly. How often? Every year, right? And what else is important for them? It's a common bacteria that causes a lot of pneumonias. Strep pneumo, right? So pneumococcal vaccine is also really important for those patients to make sure they're up to date on that. Anyway, and obviously if they are smokers, certainly there are some patients with COPD that smoking is not a primary issue there, but certainly for the majority of them it will be. So smoking cessation is important. We'll talk about that in a moment. Now getting into the medications themselves, certainly short-acting beta agonists are going to be useful here. Occasionally you may see some anticholinergics being used, like a short-acting one like ipratropium, not real common, but albuterol certainly going to be the starter here. Also, when you're looking at your long-acting bronchodilators, this is where you have a few more options here. Certainly you can consider things like, for long-term bronchodilators, what do we have options available to us? Salmeterol, which is what? Long-acting beta agonist, right? Yeah, so salmeterol will be an option there. What's another, say, a different mechanism? What can I do? Remember, anticholinergics could also be used as well. This is where Spiriva or tiotropium comes into play here, right? So either one of those could be used potentially. I do start to see a lot more of drug commercials and things like that, really pushing the combination of a long-acting beta agonist plus what else? Yeah, an inhaled corticosteroid, right? Because again, it has to do with chronic inflammation. By using a corticosteroid, that can kind of help out with that. So again, you can kind of work your way up to using combination of the medications here. So they may be on a combination long-acting beta agonist with an inhaled corticosteroid, and then they also have something like Spiriva on board as well in order to help kind of manage that. Try to keep those airways as patent as long as possible, right? Another thing you may consider here as well is, again, with these patients, the leukotriene pathway is not so important, so things like Singular are probably not going to be used for the majority of these patients here. However, you may consider for some patients theophylline, right? Theophylline may be of benefit. We mentioned what are some problems with theophylline. Do we use it for like a lot of patients? A lot of asthma patients? No, right? Because it's kind of a crummy drug. It's pretty old. It's effective for what it does, but it has what kind of therapeutic index? Narrow therapeutic index, right? So you have to do drug level monitoring. It can cause a lot of side effects, not good for patients with seizure history or cardiac history, with arrhythmias, things like that. Not great. So I'd probably hold off on using theophylline unless you have a really stable patient, that might be a good option for. But again, kind of working on just getting further optimizing that combination therapy. Obviously, another really big thing for these patients is to provide them oxygen. That's really important. It helps with a lot of the symptomatology for those patients as well. However, is there any problems if a patient's like still smoking along with oxygen? What could happen? Not great, right? So I had one patient who came into it was a level 1 trauma. You're always thinking, oh, there's a big car wreck. What the heck's going on? Apparently, it was a guy with COPD, long-standing COPD, was smoking, had his oxygen on, and was cooking over a gas stove. Not great. The patient did not do very well there, right? Anywho, very important for education points. But yes, oxygen is going to be really important here as well, but I won't get too deep into that just because it's not really my purview, so to speak. Now, how do we keep people from smoking? What do we do for them? So they said patches. Patches of what? Nicotine, right? So we do nicotine patches. What's the role of nicotine patches? What does that do for us? It helps with cravings, helps with urges. What do you call that when you have this sudden, you're taking away that nicotine? They say stop cold turkey. Withdrawal, right? So just like you have opioid withdrawal, like alcohol withdrawal, you can have nicotine withdrawal, right? So that's what causes all those cravings, because again, that dopamine pathway is not really being activated any further. And so we're going to see that a lot of therapies to keep people from smoking, are they all that effective? Generally, no, right? So we will find that by using combinations of therapies that you will be able to get additional benefits, right? So by using things like cognitive behavioral therapy in addition to, say, nicotine replacement, you get additional benefits than you would by either one alone. And obviously things like cold turkey, success rates are quite low, right? Unless you have someone who has a really indomitable spirit and iron will, they can quit that cold turkey. Very difficult for a lot of patients. So what you're going to find is that we have several options here, right? So we'll talk about these as we get along. Notice here the majority of them are going to be nicotine replacements, right? So what does that do for us in terms of replacing that nicotine? It's basically giving them back what they originally are addicted to, right? So that way they can slowly wean off of it over time. The point is to stave off those withdrawal symptoms, and that way they can slowly wean off of it. We'll look at a few other agents here like Bupropion and Varenicline or Chantix here as well, because they offer some novel mechanisms. So talking about Bupropion here, anyone know what this is normally used for? Depression, yeah, absolutely. So originally it's used for depression. We'll talk much more about this in the psych section next semester, but originally a lot of the antidepressants that we have, some different mechanisms here. The primary ones we have nowadays are the SSRIs. Anyone know what that stands for? Selective serotonin reuptake inhibitor, right? So they block reuptake of serotonin, you increase serotonin levels in the synapse, and then yada yada yada, and then you fix your depression, right? We don't really know what the yada yada is, but you fix the depression. So what's interesting about bupropion, it actually works not necessarily on serotonin so much, it actually works on dopamine. And we know dopamine is really important for those reward pathways, and so what some people feel that bupropion does is it kind of helps to reset that dopamine pathway a little bit by helping to regulate levels of dopamine, such that instead of having this massive withdrawal of nicotine and thus not stimulating that dopamine pathway, you end up having some regulation of it such that you help to stave off those withdrawal symptoms, right? Hopefully will prevent those intense cravings. And in fact, is bupropion only used for smoking cessation? What other things could you use it for, addictive sort of conditions? They're actually starting to use it for overeating disorders, right? So for patients who will binge eat and things like that, they can actually use this to help regulate that dopamine pathway such that they don't have those intense cravings to eat a ton. And that's actually one of the things you can see with antidepressant medications. Some people actually develop weight loss associated with that. Bupropion could be one of those agents there. So you may see that in some combination drugs that are coming out in the market nowadays for weight loss. Anyway, we use it originally here for smoking cessation. And basically, things you want to be careful with is patients with seizure disorders. Bupropion can exacerbate that and lower that seizure threshold, so you want to be careful with that. And obviously, if they're taking any other medications that work through dopamine or norepinephrine pathways, bupropion can also lead to some toxicities there. So you want to be careful and not mix this up. Say, for instance, your patient had a history of depression and they want to stop smoking. Maybe a good idea to maybe switch them from their SSRI maybe over to bupropion by itself, and then there you go, right? So you get kind of two birds with one stone, so to speak. You'll see a different brand name when it's used specifically for smoking cessation. Anyone know what that is? Like for depression, it's Wellbutrin typically. How about for smoking cessation? You ever see Zyban? That's the brand name that's going to be marketed under that. Is there anything different in the medication? No, but they get like a new patent on it and they market it a little bit differently, but it's the same drug, right? So nothing special about that. Anyway, so we'll talk a lot more about that later on. So nicotine replacements, this is good because it helps to minimize a lot of the withdrawal symptoms there, the irritability, the anxiety, insomnia. All these things are going to be pretty bothersome to your patients there, especially if they were to quit, say, completely. The idea here is you kind of give them a replacement dose of nicotine sort of close to what they were getting before, and then you gently wean them down over a period of, say, weeks to months, right? Some of these are available over the counter, so patients can get access to this on their own. Patches, gums, things like that. Some of them are going to be more restricted a little bit there, but certainly a lot of patients are now using things like e-cigarette systems and things like that. We've already kind of briefly mentioned some of the drawbacks to that, mainly being we don't really have any good regulations on the e-cigarette market. We don't really know what's in that stuff and what the long-term ramifications there are. It's important though, if you say your patient was taking a nicotine patch, what if they start smoking on top of that patch? They fall off the wagon. Is that a good thing? No, why not? They're giving more nicotine than what they were getting beforehand, right? So it can see some toxicity associated with that. So you want to educate your patients, hey, if you end up relapsing, going back to using a cigarette, then you need to make sure you take off the patch or you're not using the gum along with it, things like that. Now, what if a patient were to, say, fall off the wagon, so to speak, and while they're on Zyban, Bupropion, would that be a problem? Not really, right? So that's one of those things where you want to know, hey, how likely is my patient actually going to keep smoking? And that way, bupropion is not going to have interaction. This is giving them more nicotine, so of course that would be a problem. You can see much larger effects than they would be by themselves. Other concerns you see with like nicotine replacement products as well is with, for instance, if you throw a patch into the trash, is that patch devoid of any medication? No. So who's that a problem for? Little kids. Who else? Pets, right? So you have to be careful, make sure they're disposed of properly, where they cannot be ingested potentially. How about like the gum products? Do people like gum? Yes. Do kids like gum? Yes. So they say, oh, mommy or daddy are eating their gum. I want some gum too, right? You can see toxicity from that. And again, with potentially small children, nicotine can be really problematic. I mean, we had some kids, I know we had one case where a kid had gotten into the parents' e-cigarette refill liquid, and basically there's no child protection on it. Able to open it up, get the whole thing, the kid became very limp and listless and had to get rushed to the ER. Fortunately, responded well to supportive care and did fine. But nicotine itself can be a neurotoxin, right? It can actually cause, because what stimulates your muscles to contract? Acetylcholine working on nicotinic receptors, and if you overstimulate those receptors, you end up developing paralysis, and that's actually how we can induce paralysis to intubate somebody, that same mechanism. So nicotine can do the same thing. So it's a really big problem for small children getting into that, right? Also keep in mind there's also, you know, a lot of social and even physicality to the act of smoking that some patients really get a lot out of, that habit, you know, so to speak. So I remember when I was in college in undergrad, we had this professor named Dr. Healy, and he was probably like 900 years old. And I assumed helium was named after him. He was such a pioneer. But anyway, but he would always hold his chalk when he was up at the board. He would always hold it like this, and he had this kind of tremor to him. But it was just, you could tell he was just a long-term smoker and had the voice to go along with it. But it's that physicality that some patients really get a lot out of. So a patch is not really going to replace that. So in some cases, using something like a e-cigarette can actually be beneficial because they still get that feeling like they're smoking, even though they are gently weaning down off of their dose. So just something to consider. Anyway, getting to Varenicline or Chantix, this is the newest medication we have for smoking cessation, and this one offers a pretty novel mechanism here, where it's actually going to be a partial nicotine receptor agonist. So what do you think this is going to do for us? The partial agonist is going to bind to that receptor and only partially activate it. What do you think it'll do to withdrawal symptoms? It'll help to mitigate them, right? Is it going to get rid of them completely? Likely not, right? What would happen if a patient were to, say, start smoking in addition to taking Varenicline? Would it be as bad as if they were, say, on a patch? It's not going to be as bad because, again, some of the receptors are being occupied by Chantix, and such that if you started smoking on top of it, it would not necessarily have as many receptors to activate, right? It would not have as big of a problem. And in fact, they actually tell you 1 week before your quit date, start the medication. That way they are smoking while taking Varenicline, and then they will hit their stop date, stop smoking, and then the idea is you have enough drug in the system to try to help keep those nicotine receptors partially activated, they don't go into those severe withdrawal symptoms, right? So again, a novel mechanism. Some people report really good utility from this. However, oftentimes patients will quit taking the medication due to some of the side effects. And so this is kind of a unique sort of thing here, where it has actually a black box warning for certain neuropsychiatric events like depression, suicidal ideations. I mean, some patients, when they quit smoking, they probably want to kill themselves anyway because they feel so miserable, but hopefully this will not because of this drug, but it's certainly something to educate on. But also the dreams are really kind of interesting here. So has anyone ever talked to someone who's taken Chantix before? The first thing they always talk about is the dreams, right? Super vivid, super, like they just feel like they are there in the action, whatever's happening. If there's purple elephants or flying or whatever the case may be, it's super vivid. They think it's really real. Some patients, that's fine. They have no problems with that. Some patients have some significant nightmares from this, and so that's enough to where they actually want to stop taking the medication altogether. So just be aware that is a possible side effect. Okay. As we mentioned with immunizations, pneumococcal vaccine and yearly influenza are going to be recommended for them for sure, so make sure they're up to date on that. Okay, so any questions on the pulmonology section? So if I said like a patient was taking, say for instance, they wanted to quit smoking and they had a history of depression, what would be a good option for those patients? Yeah, Wellbutrin or bupropion might be good. What would be a bad option? Why a Chantix? Cause worsening depression. What's actually interesting though, and we'll talk about this as sort of an oxymoron a little bit later on, is that actually all the antidepressants carry black box warning for increased suicidality. It's one of those things where it's like, why would we give you medications that make you want to kill yourself when we're trying to make you not want to kill yourself? It's just one of those things with the medication. We'll talk more about that a little bit later on, actually next semester, so you can keep that in the back of your mind. Let's move on and get into the next section, which is going to be dermatology. Who has a burgeoning interest in dermatology? I think of at least one individual. Anyone else? Yeah. A lot of you actually go into dermatology, and this is a good state for it, right? We get a lot of sun exposure, we get a lot of skin cancers, things like that. But I will tell you, in terms of my interest, derm is not a particularly high one. It's just not something I practice a lot of because, again, of where I work and kind of my exposures to things. And so, again, I'm by no means the end-all be-all expert on dermatology, right? So this is sort of the introductory sort of course. If you talk to someone who does day in and day out, they're going to be able to give you much deeper insight, but at least get the basics covered. And again, have you started derm and CMS yet? Yeah, so again, we'll talk about this. If there's anything conflicting, always bring it up. We can talk about it. Again, a lot of times it just has to do with different perspectives, and usually we can come to some kind of consensus. Anyway, so let's talk about the sort of an introduction to dermatologic products. So again, these are going to be things we're placing on to the skin, right? So when we say topical, specifically that's what we're referring to here. And again, when you apply drugs topically, do they only work locally? It depends, right? Like that's another good answer. Not necessarily. Okay. It's not necessary, but yeah, so we're going to see that some medications will have systemic actions. Some drugs are going to work much more locally. What will dictate if a drug is working systemically? The concentration, I heard, is a good one. What else? Higher concentrations probably mean more absorption, right? More systemic effects potentially because of that. What else? Lipophilicity, right? So if you increase the lipophilicity of a substance, does that go through the skin better or worse? Much better, right? Because it can get through all those membranes and be able to actually get absorbed to the systemic circulation. So a lot of different things matter here. Also, where on the body you're applying it is going to matter as well, right? Not all areas of skin are the same thickness, such that places like the face, places like the axilla, the scalp tend to be more permeable just because that membrane is going to be thinner, right? The barriers you're having to cross are going to be thinner there. I mean, that's important because you can see some significant absorption from those areas, in some cases toxicity. And I probably mentioned a case before where an infant was having diaper rash and the mom accidentally got the dad's back pain cream and it was full of ketamine and tricyclic antidepressants and all kinds of stuff, applied it onto the diaper area, onto to the area there, it put the diaper on, and guess what? And they have an occlusive dressing on top of an area that is very inflamed because of diaper rash, and just the kid got a ton of absorption. Again, what do you think about kid skin versus, say, an adult skin? Much thinner as well, right? So again, all these things are going to be playing a role in terms of how well they get absorbed. So, and you guys remember that law we talked about back on pharmacodynamics that governed a lot of that? fixed law, right? So fixed law was very important. And again, a lot of those things were sort of intuitive. You know, that if you say apply a drug to more surface area, what does that do to the absorption? Probably increases it, right? If the membrane is thinner, it probably increases it. If I increase the concentration, lipophilicity. So again, a lot of these things are going to be very intuitive. And again, especially when we talk about corticosteroids, this is going to be important because we do know corticosteroids can have significant systemic effects, and we can look to see how we can either enhance that or mitigate that depending on the formulation that we're going to choose. So anyway, so a lot of times your skin can also act as a reservoir for these medications, right? So onset of action for medications applied topically, say if you're trying to go for a systemic effect, is it pretty slow or pretty fast? Say compared to IV. Very slow, right? So again, for instance, if I were to say put a patient, you guys are familiar with the opioid analgesic fentanyl. Ever heard of a fentanyl patch? Right? So those patches, what's interesting is if, say I had a patient who's in the ICU and they were on a fentanyl drip, and I want to convert them over onto a fentanyl patch. Actually, I'll slap the patch on the patient, gently, right? We want to be nice to our patients. But we'll put the patch on the patient, and then actually for a period of time, we'll keep that drip going, and then eventually we'll cut it in half, and then we'll cut it off completely, because we know that if I were to stop that IV infusion of the medication, as soon as I put the patch on, what's the patient going to have happen? The drugs are going to run out very quickly because it takes time for it to absorb through the skin, right? It has to come to that equilibrium, and so that depot effect is important there. Also, if I were to say take the patch off, a patient been on the Duragesic patch for say many weeks, and I take it off all of a sudden, does that mean the drug effect is gone immediately? No, because the skin's still holding on to stuff, right? So you're still going to see some absorption there. So that's important. May lead to less frequent dosing for some of our shorter acting medications because of that depot effect. Anyway, so when I talk about vehicles and occlusion, so vehicles, what does that mean in terms of topical medications? I mean, is that like sweet car I'm going to get when I'm working in Durham? No, we're talking about the vehicle. What are you actually putting the drug into in terms of, is it a lotion, is it a gel, is it a cream? All these different factors here are going to be playing a role. Some of them can be drying, some of them can be moistening. You're going to see lots of actions here depending on the vehicle. Very frequently, the vehicle itself is going to be more therapeutic than maybe the drug you're putting into it, right? Depending on what you're actually treating. When I say occlusion, what does that mean? What's the staying power, right? So again, if I apply something, say for instance, I were to apply, say a shampoo or something onto the skin, right? Does that stick around for very long? Washes away pretty quick, right? So it's not very occlusive versus if I were to say take a big glop of Vaseline, slap it on your skin, does that stick around? Yes, it does. It's much more occlusive, right? What if I put, let's say, a wrapping over it? That helps increase the occlusiveness of the drug, and that's going to find that one can enhance therapeutic effect, but also enhance toxicity potentially, right? As I mentioned, putting a diaper over an area where you've applied, say, a medication, it increases the occlusiveness of that. That's why the kid got so much absorption, and in addition to all the other factors that went into that. But so again, we'll talk about some of those factors there as we get into it. So anyway, so considerations in terms of, what sort of vehicles our drugs can go into. Well, one, is the drug even soluble in the vehicle, right? So depending on how lipophilic or hydrophilic the medication is, if it doesn't go into solution, it's not really going to work all that well, right? Also, how is the ability for the vehicle to actually hydrate the stratum corneum? That enhances the penetration. Really dry, scaly sort of skin is going to have a difficult time penetrating through because it's just dried out and it's not a lot of moisture for it to actually penetrate through. So if it's hydrating, that can be sometimes helpful there. And then also consider the stability of the drug in the vehicle. Let's say stability, what does that mean? How long until it breaks down? Sometimes this can refer to, we can also talk about, the sterility of the product as well. Do you have a bunch of microbes that are going to be growing in there? Do you have to include preservatives to prevent that from occurring? So anytime you put a medication into sort of a more aqueous sort of medium, you tend to decrease the stability of that medication in the long run. That's why a lot of times if you see like a vial of medication, it comes as a freeze-dried powder. Has anyone ever seen that before? Where you have to reconstitute the drug. That's because by taking all the moisture out of it, you increase the stability and the shelf life. Drugs that are in this different topical vehicles, you're going to find that may be an issue for some of them. So looking at your different options here, you're going to find that there's quite a few, right? We'll talk about some of these more frequently than others, some of the more common ones. But you can tend to see that things that are more lipophilic, things that are more oil-based, tend to have more occlusion. They tend to stick around for longer. They tend to be greasier. They tend to be more moisturizing in a lot of cases here, versus things that are going to be more, say, alcohol based. Now, alcohol itself, does it evaporate pretty quickly? Yes, those tend to be very drying, right? So if you imagine using, we're talking about acne and things like that. A lot of those products may contain some alcohols that can be very drying, can be very irritating. So depending on the type of skin that you're dealing with, you may want to use a more drying or more hydrating sort of formulation there, right? So that can be very dependent on how the patient's presenting, what the skin looks like. So anyway, so just a few things I would like to compare between the different vehicles you'll commonly run into. So we're kind of at the top here, we're looking at creams, ointments, gels and foams, and then kind of lotions, solutions, and some other types of foams you may run into. So just some of the big salient points I want you to take away from this is that looking at the physical basis for these can change depending on the vehicle you're looking at. So for instance, creams are going to be, say, an oil and water emulsion, where the water content is going to be more predominant than the oil part, right? Now normally do oils and waters mix? No, but we can put them into suspension potentially, right? Sometimes those have the ability to separate out. Sometimes we'll add things to try to keep them into a suspension a little bit easier. But basically the water content is going to be higher here. And that kind of makes sense when you're looking at this, say greater than 31%, for instance. For ointments, and again, an ointment sticks around for longer than a cream, right? Tends to be a water and oil emulsion. That means that the oil content is going to be much higher there. So it means it's going to be sticking around for longer. How does, like, say, an ointment feel compared to a cream after applying it? Greasy, right? Now, is that a great thing for the patient? No, oftentimes they don't like that feel, and so that can be an issue of compliance. Maybe you want to choose a cream versus an ointment potentially. However, that oil that they're leaving behind, that greasy feeling, can be good because it keeps the medication around for longer. So it can increase the contact time, increases how well the drug's going to be working there. Remember we talked about in ophthalmology how the longer the drug stuck around for, that contact time, the better it worked. Same thing can happen here with dermal medications, right? And then looking here like gels and foam, sometimes you may find these may be more alcohol based, the water content may be higher, just depends on the formulation you're dealing with, right? So anyways, looking at the advantages here, with the oil and water emulsions, with the creams, again, you're going to leave some amount of drug concentration on the skin there. With the ointments, though, you get even better effect because that oil, that greasy sort of protectant effect is going to be around as well, which is nice. Gels and foams, though, non-staining, greaseless, so that can be a nice benefit to some of your patients. They might prefer that, right? Looking at how easy it is to spread, how easy it is to wash off, etc. Those are all things that maybe you're looking for. Now, locations on the body. Now, why do you think with ointments you want to avoid these intertriginous areas? Not necessarily for bacteria. It's a good thought, though. Most of the time it's going to be because of the staying power of those medications is so much better with something like an ointment. They tend to increase the absorption of those medications. So, for instance, something like a steroid, you could end up seeing significant systemic effects by applying steroids to those intertriginous areas. And if you use it in an ointment that has better staying power, that can increase that even further. So, again, that's a general consideration, may not be used in all cases there, right? Now, also looking here whether it needs preservatives or not. Typically, the higher the water content, the more likely bugs are to grow, and so that's when you use more preservatives and things like that in order to keep the compound sterile and also stable, as the case may be. Just looking at occlusion, again, low versus moderate to high when you're dealing with an ointment. That kind of makes sense based off what we talked about already, right? So anyway, so those are kind of the general sort of things here. We'll talk more about that as we get into specific options coming up, though. Okay. So, any questions on that? All right, so getting into talking about acne. So, why do people develop acne? It's a rite of passage for humans in life. Everyone has to experience it at some point. There's a lot of factors that go into it. I mean, there's certainly genetics factor into it, environmental factors. There's a lot of different things here. The things I do want to focus on, though, is the pathophys, because that's going to be directly influencing the type of medications we're going to be using for those patients there. Typically, 4 major factors that happen here, and we'll show you some pictures here that kind of make this more sense of that, is one, you're seeing this increase in sebum production, right? So these are starting to block out those follicles. That also will end up leading to some of this abnormal keratinization and this hyperproliferation. So sometimes you get some covering there of those follicles, and then you end up finding bacteria tend to like that environment. What type of bacteria like that environment? It's clogged up, and there's not a whole lot of air there. Anaerobic bacteria, right? So for instance, this Bupropion bacterium, acnes, is actually going to be one of the main ones we're targeting there, and actually it's an anaerobe, which makes sense, and I'll show you pictures that make more sense of that as well. And then from that, your own body is going to be attacking that in terms of increasing inflammation, which leads to a lot of irritation, things like that. Those are kind of the four main steps here. And certainly other things can factor in here in terms of like environmental factors, heat, humidity, all things like that can play a role here. Certainly different hairstyles, excessive scrubbing, anything like that can certainly affect this. And not only that, but like physiologically speaking, if you're stressed out, you're releasing a lot of corticosteroids, a lot of cortisol. What does that do to your ability to fight infection? It decreases it, right? What does it do to, say, like your blood sugar? Increases it, right? So you're kind of priming the stage a little bit for these bacteria to grow, and thus that can also sometimes lead to exacerbations of acne for individuals who are more susceptible to that. It's little things to think about. Not that any of you are stressed at all for any particular reason, right? Anyway, so again, looking at the pathogenesis, again, this kind of these four steps are happening here. Pooling of that sebum is creating this nice anaerobic environment. This is where you're going to see proliferation of the bacteria. They're going to be mainly causative here for acne. Once that starts to take hold, just like any other type of infection, you're going to see inflammation start to build up due to the host immune system. So T cell activation, inflammation here. Not only that, but also you're going to find that the lipase from the bacteria itself is going to sort of break down triglycerides into free fatty acids, which can increase inflammation, which also causes some of that keratinization and that microcomedone formation there, right? And then cytokine production, chemokines, starts to break down on the material in there, and that's where you start to get the pus that develops underneath there. And certainly you can find some cases where it's more or less inflammatory depending on the condition, depending on the factors that kind of led up to it. And so you can see that by looking at these different steps here, we'll have medications that may work on one or several of these different steps. And that'll be important because are all patients with acne, are they only managed with one medication? No, sometimes they need multiple medications, and again, by using different steps along the pathway here to treat that, you're going to find better synergy, right? So synergy is going to be better. You're going to get better effects out of just using either medication by themselves. And here you can kind of see in this picture how this increased sebum production just kind of causes blockage and makes it nice and anaerobic, makes it nice and very hospitable to those bacteria to start to grow. And again, just the inflammation gets worse and worse, and then that's where you end up seeing eventually that all those lysozymes and everything's just kind of digesting everything. That's where that pus starts to develop underneath there. So what about drug-induced acne? Do any medications potentially cause acne? I have a whole slide about it, so you assume yes it does. Systemic corticosteroids tend to be a pretty common one you can see here. So again, what are some systemic corticosteroids you can think of? Prednisone, dexamethasone, methylprednisolone, yeah, all those are good options there. And in fact, I think we were having a fire sale on dexamethasone yesterday in the ER, because I think every single patient coming in was getting dexamethasone orally once, and then what else do you think they were getting? The winter season, coming into the peds ER, albuterol as well. Right, so a lot of asthmatic kids that are presenting to the ER. So a lot of albuterol, 2.5 milligrams, Q15 minutes times 3 doses is a very common sort of order you see there in the ER. But anyway, using a lot of corticosteroids for those patients here. But this is more for patients who are on it more long term. This is certainly if you're seeing it for, say, patients on long-term corticosteroids for, say, rheumatoid arthritis, something like that. But anyway, and again, with systemic corticosteroids, do you think it would just be limited to the face? Well, no, it's a systemic corticosteroid. You can see it potentially anywhere, and so typically the trunk is going to be a little bit more affected there. Hydrocortisone is going to be typically the least likely to cause this. It is pretty minimal in terms of its effects. It's kind of the wimpiest of the steroids, as we'll talk about a little bit later on, but certainly anything greater than that in terms of potency could certainly cause that. Different medications too, things like antiepileptics, things like tuberculostatics, like we mentioned just a few the other day, things like ethambutol and pyrazinamide, things like that potentially can cause some drug-induced acne. And then lithium as well. What do we use lithium for? Yeah, bipolar disorder, right? So that can also cause some drug-induced acne. So anyway, so what's our treatment goals here for these patients? So again, this can be a chronic disease. Some patients may grow out of it, so to speak, but oftentimes you're going to find that it'll, similar to other disease states, you want sort of early aggressive treatment, kind of get things under control, especially in terms of inflammation, and then they'll be on some degree of maintenance therapy, and then you kind of can step up therapy as need be for those flare-ups. All right, if we can get down to slowing progression of signs and symptoms, decrease those relapses there, it can be very beneficial. Obviously, if we can prevent any sort of psychological suffering for your patient, that will also be beneficial to them, right? So our treatment, as I mentioned, we're going to be targeting those 4 steps along the pathway of acne. You're going to see this microcomedone is the thing we're really going to be targeting here. By eliminating that follicular occlusion, that was going to arrest the rest of the cascade there, right? So what does that mean? By opening it up, getting exposed, say getting oxygen in there, what does that do to the ability for that bacteria to grow? Prevents it, right? Because it's an anaerobic bacteria, right? So, and again, we're going to focus both on non-pharmacologic and pharmacologic therapy, right? We're going to see how these can play together nicely. As we mentioned, have multiple mechanisms of action working together, have targeting multiple pathogenic steps, also going to be beneficial. Most often for more mild to moderate disease, especially if it's localized just to certain areas, topical therapy can be sufficient for a lot of those patients there. For more moderate to severe or say more diffuse disease, this is where systemic therapy is going to be more warranted, okay? So we'll talk about the different therapies and kind of we work it through it in a sort of stepwise sort of approach. So first off, talking about non-pharmacologic therapy in terms of cleansing, what are we using to cleanse the face or anywhere we're trying to get rid of that sebum, right? Sebum itself, is it fatty? Is it watery? What is it? It's fatty, right? So how do we get rid of that? With soaps, right? We use surfactant systems, and essentially any soaps are essentially that, right? So by using these surfactant systems, we'll disperse and remove those fats and oils from the skin, and will then allow those follicles to start to breathe again, and hopefully prevent those bacteria from growing there. However, what's kind of the downside if you say overdo it and you're cleansing too much? Skin gets really dry, gets irritated, that gets inflamed. Again, you kind of run into the same problems. You're sort of shooting yourself in the foot, so to speak, if you do it too frequently. And oftentimes you're going to find that soaps may not be the best products because, again, once they are washed off the skin, they're not there anymore. They're not really doing anything at that point. Also, some of them can actually inactivate other products you may be using. So typically, you're going to find that as long as we're not doing it too frequently, say just limit it twice a day, that generally will be sufficient for most patients there. Also note here that due to the high pH, right, because soaps typically have a higher pH, usually more basic, again, that can be less tolerable on the skin for some patients, and then just the inactivation of some products is a problem. So getting into the topical therapy. So obviously this is only going to work to where you're specifically applying it to, which is why I mentioned if you have more diffuse disease, is topical therapy always going to be really feasible? Well, no, right? Because again, if I'm going to apply it over the majority of the body or the trunk, that can be kind of problematic for them. So that's where more systemic therapy can be beneficial. Most of these you're going to find tend to cause irritation, right? Some of them may be pretty mild, some of these can be pretty harsh, as we're going to see going along, and a lot of times that can lead to discontinuation. Their skin feels worse than it did beforehand. They're saying, why do I even stick with this medication? So sometimes you need to make sure you're starting low and gently work your way up to see what they can tolerate from there, right? Also consider using non-alcoholic solutions. What do you think that is? Alcoholic solutions can be very drying because that stuff evaporates very quickly and will take a lot of moisture with it. So again, try to avoid those. That will help with some of the irritation. And you'll see here how our different medications are going to be working on these different steps here. And so we'll get into each of these individually as we go along, and we'll talk more about them, but you can refer back to this to kind of see where they're working at. So first off, we have benzoyl peroxide. So is this something you get over the counter? Absolutely, right. So do you think if patients are presenting to you and they're complaining of acne, do you think this is maybe something they've already tried? Yes, probably, right? And that's always a good question. What have you already tried? Because a lot of things they may have tried, maybe some home remedies, maybe they tried something that their great aunt said, this stuff works, it's great, try this stuff. Figure out what they've already tried, because if you're going to give them something they've already had and it worked for them, it's probably not going to be beneficial at this point. So, but also consider, having access to prescription-based products that may be stronger, they may have different formulations that may not be available over the counter. So something to think about. But using benzoyl peroxide is going to be sort of our first step for a lot of patients here. Basically what they're going to do is benzoyl peroxide is actually going to penetrate into the skin and gets converted over to benzoic acid. The acid form of it actually has pretty good activity against P. acnes, right? So it's good anaerobic activity specifically against that bacteria. Also has some peeling and comedolitic effects, right? So it's able to kind of break down the abnormal keratinization and help to kind of with that peeling there. Again, that can lead to irritation. So again, another common side effect with these. Typically starting at a low concentration, say like 2.5% or so once daily, and then gradually increasing as time goes on. Okay, to see what they can tolerate. See what they've already had before, maybe already start with a little bit stronger if they've already tried over-the-counter varieties. Now you can find that benzoyl peroxide is a good sort of backbone sort of medication to a lot of other meds. So you may see these used in combination with things like erythromycin, Clindamycin, again, we've already talked about these antibiotics. We'll talk more about them in a few minutes here. And then other adverse effects you do want to be careful of is it can bleach the hair. So be careful if you're like applying around the hairline. One thing to note, it can bleach clothes as well, right? So frequently, when do you think you'd be applying this? Morning or night? What do you think? Depends. We'll actually find some medications are better given at nighttime. We'll see why that is in a moment. But yeah, think about, if they're going to be like, say, putting it on and then putting on their school clothes, right? They can bleach those. That may not be great. So maybe nighttime might be a better time for them to administer it. Just depends. And then again, depending if it gets anywhere near any kind of mucous membranes, that can also be quite irritating as well. Similar to benzoyl peroxide, you have azelaic acid, or Azelex. This is actually, it has some additional benefits over benzoyl peroxide, but has sort of similar activity here in terms of its antimicrobial effects here. Also, an interesting thing that it does as well is it actually inhibits conversion of testosterone to dihydrotestosterone. Have we talked about that at all before? What's the difference between testosterone and DHT? Well, they're both active, but DHT is more active, right? So you tend to find that DHT is a stronger androgen sort of effect than testosterone is, okay? And this would be important because, for instance, testosterone, what sort of organ can it stimulate the growth of, say, in older gentlemen? The prostate, right? We'll talk more about that in urology next semester. But actually one of the drugs that we use to help treat BPH, or benign prostatic hyperplasia, is a drug that prevents conversion from testosterone to DHT, because DHT is so much more potent of an androgen than testosterone is. But this can do the same thing in the skin, and we do know that testosterone can have what effect on acne? It can worsen, right? It can increase that sebum production. It can make things. So again, this is another medication that working locally can try to help change the environment a little bit in terms of the steroid activity here to try to make it more inhospitable to the bacteria, less inflammation, etc., right? So again, these drugs here, mild skin irritation, dryness is going to be common with the majority of them. This is going to see improvement over time, especially if you have your patients stick with it over 6 to 8 weeks or so, should have improvement with continuous therapy. And also another side effect you may see is hypopigmentation of the skin. So one thing you might be wary of, just something to monitor for. Okay. So those are kind of the baseline medications you might try here. Now we're starting to get more into like prescription-based therapy here. So we're getting into the topical retinoids. Anyone know what vitamin this is similar to? Vitamin A, right? So these are interfering with vitamin A. Basically, they're the acid form of vitamin A. Vitamin A is also important for what organ function? The eyes. They help us with what? Yeah, vision essentially, right? Because they are important for rhodopsin and all of that, right? So I keep forgetting I didn't teach you guys physiology. So I was like, you had that lecture, but I know Professor Kaplan gave it to you, so I'm sure he talked all about that. Anyway, so getting into the topical retinoids, again, we don't know the full mechanism, but the retinoids are nice because they work on several different mechanisms here. We do know they have effects on preventing that keratinization process from occurring. They do also have some chemolytic effects. They help reduce those P. acne counts, and they reduce inflammation. So for the most patients, this can be first-line therapy for a lot of them. So especially for non-inflammatory acne, this could be a good first stop for a majority of them. Also, you can see it being used for things like wrinkles and dyspigmentation, right? So is tretinoin, is this available over the counter here in the US? It is not. What's interesting though is if you ever go on a 3-day cruise, I remember my wife was very excited. We stepped off in Nassau and we decided to go check out a local pharmacy, and she saw tretinoin was available over the counter. She said, I'm going to buy a ton of this stuff. I said, what are you using it for? You don't have acne. She's like, for the wrinkles. And I said, you don't have any wrinkles. She's like, exactly. Prevention is better than treatment, right? Yes, ma'am.
This does not have to do with dermatology, but it has to do with things being over the counter in other countries. Like, I saw they had tramadol offered over the counter in like Mexico and stuff like Costa Rica and stuff like that. How are they able to do that with, do they see a lot of overdoses and stuff like that? Or are they more?
It depends. Yeah, I don't know specifically about other countries in terms of what they have available over the counter. Sometimes they will regulate it based on the dose that's available. So for instance, when we went to Nassau, they had Tylenol with codeine available, but it was a lower dose than, say, the typical Tylenol number 3 that you can get over here. So sometimes the dose matters, right? Sometimes the regulations are such that having easier access to it, maybe they don't see any additional overdose effects. I don't really know what the overdose rates are like in Mexico, for instance. But yeah, it's definitely interesting for sure. But yeah, different places will have totally different regulations. Some places actually have a third tier of medications where it's like pharmacists prescribed, like in the UK, they'll do that sometimes. So yeah, everywhere you go, it could be completely different for sure. But anyway, good question. So, like I mentioned, topical retinoids, good first line for a majority of patients there, right? So adverse effects, again, very irritating on the skin. Obviously, the higher concentrations you go with, the worse that's going to be. So you can see things like erythema, desquamation, burning, stinging, etc. This can be partially mitigated by using emollients and things like that along with it. But be aware, like you can't see a lot of photosensitivity. You can see severe sunburn associated with this. However, the drug mainly works, or actually, when do patients mainly apply tretinoin? At nighttime. You know, why do you apply it at nighttime? Because of the sunburn issue, but also it's photolabile, which means light breaks it down. Light actually inactivates it. And so this is why you apply it at nighttime, because it's photolabile. Also, hopefully if you're sleeping and then you're in it, you're not going to get too many sunburns, right? But you never know. Maybe you have someone who works night shifts and they sleep outside on their porch, who could say, right? Anyway, but also interesting to note, benzoyl peroxide will inactivate tretinoin. So you would want to separate these out. So maybe you'll have a patient who's taking, say, benzoyl peroxide in the morning time, when they're doing their morning shower routine and whatnot, and then maybe apply tretinoin at nighttime, right? So again, sometimes you can see that scheduling can be important in terms of that, right? Now, avoiding this in pregnancy, what do you think that is? Generally, any medication that mucks around with fat-soluble vitamins is terribly teratogenic to fetuses. And we're going to see systemic retinoids are also going to be very notorious for this. And so you always want to be careful of that. And again, a lot of your patients who may be using tretinoin may be of childbearing potential, right? So again, education is a really important point here. This will not be as severe of an effect as some of the other drugs we'll talk about later, but it is something just to educate on. Some other retinoids that kind of fall into the same category, we have things like adapalene, which is nice because this one is actually stable in sunlight and with benzoyl peroxide. So maybe if patients had scheduling issues, or maybe tretinoin itself wasn't working all that great, maybe using something like adapalene could be a little bit more beneficial to them. Still the same issues of photosensitivity, so do want to make sure they're using good amounts of sunblock and they're not staying out in the sun and more likely to develop the sunburns there. But even some of these other ones like tazarotene, alitretinoin, some of these can actually be used for certain types of cancer. So for instance, like alitretinoin used for Kaposi sarcoma. Anyone know who gets that? Patients with HIV/AIDS, certainly they can develop that as a certain cancer they're more prone to. So sometimes you can find these retinoids can be useful, helping to interrupt some of these cancer sort of processes, which is a good segue because we'll talk about cancer coming up in the next section, right? Anyway. Moving on, talking about topical antibiotics for acne. So certainly there's a lot of different ones available here. So for instance, we use clindamycin. Why do you think clindamycin is preferred? What kind of bacteria does it kill? Gram-positives and anaerobes, right? And we mentioned P. acnes as an anaerobe, so you see some benefit from that. So clindamycin is good. Again, you'll find these in combination with benzoyl peroxide quite frequently. Erythromycin is another one that's commonly used for sure. Erythromycin is what type of drug? The macrolide, right? And any drug interactions you have to worry about with macrolides? Do you have to worry about topical administered macrolides? No, you're right. Systemically, certainly QT prolongation, CYP drug interactions, not topical though, right? You're not really getting a ton of it absorbed systemically. And so, just like clindamycin is known for causing what sort of opportunistic infection? C. diff. Would I have to worry about that for someone who's using it for acne? No, right? Because again, they're not getting any of it systemic. You shouldn't find any effects on the gut flora there, right? Now again, we can see resistance develop over time, so they may start to lose some of their efficacy there, which is why by combining with other things like benzoyl peroxide, you get some additional benefits there. But the nice thing here, lack of systemic side effects. However, only going to be working where you're actually directly applying it, right? Okay, so what if topical treatment is not enough? What can we step up our game to? What can we start to use next? Now we get into talking about systemic retinoids, and the main one here we're going to talk about is isotretinoin, otherwise known as Accutane. So it's a really kind of interesting sort of drug here. I'm sure some of you have known some people or may possibly have been on it yourself. Really kind of a fascinating drug because, as I mentioned, retinoids can be teratogenic, right? So they can cause severe congenital anomalies, can cause fetal death. And so because of that, we have what we call a REMS program in place. Have I mentioned REMS before? It stands for Risk Evaluation Management Strategies. And basically, it's for certain medications we know they have a particular risk with them that is so severe that we want to make sure we prevent it at all costs, right? So for instance, for there's certain psych drugs that cause agranulocytosis. So you have to get a lot of CBCs done to make sure that that is not developed. For this one, with iPledge, is the system we use for isotretinoin. It is designed to do what? Prevent any fetuses from being exposed to isotretinoin, okay? And so what does that mean? Well, it basically means that the provider has to be registered with the iPledge system, the pharmacist has to be registered with the system, and the patient has to be registered with them. And so it includes things like education on using protection, talking about using like 2 forms of protection, possibly placing them on things like birth control, having regular pregnancy tests, right? These are all things that have to be documenting. Otherwise, what happens to your script? It gets invalidated, right? It just gets taken away if they don't meet those certain things. And again, for instance, if you're at the pharmacy and we're filling it, we will be checking the iPledge system to make sure the patient's keeping up with everything. And if they're not, then we have the obligation not to fill that prescription, right? So there are things in place to try to prevent anyone from accidentally getting pregnant while taking Accutane there. Now again, men should also be avoiding this as well. Guys have to be registered additionally too. Why do you think that is? Because even they can transmit some of the drug, right? So again, because it's a systemic drug, it gets everywhere in the system, and so men can potentially transfer some of the drug over to females and affect a potential fetus while developing, right? So again, this is something that is really contraindicated: pregnancy, breastfeeding. Very good thing to know in general there. Other adverse effects too that you're going to find with this medication here, and again, give it some time to kick in, 1 to 3 months or so to really see full effects here. It's very effective at what it does, but it can cause very significant dermatitis. This medication is going to be really drying to the skin, a lot of erythema, scaling can happen here, a lot of photophobia, right? Light sensitivity is going to be a big thing, and even some interesting other things that happens due to the effect it has on vitamin A, things like alopecia, brittle nails, headaches can develop from this, and also can cause worsening signs of depression, right? So again, if a patient had a history of depression, this may not be a great drug to start out with, but certainly educate them, hey, these are things you want to look out for. Family members also should be looking out for this as well. So a whole host of problems here, but again, it's really good at what it does. So you got to weigh the risks versus the benefits, and if it makes sense for your patient, then say go for it, right? Also available to us are going to be things like systemic antibiotics, right? So this is going to be better for more extensive sort of disease. It's a little bit more widespread. Tetracyclines are very commonly used agents here. Why do we like tetracyclines, do you think? It's a pretty old group of medications and it's dirt cheap. You can find tetracycline, minocycline, doxy, all of that very, very cheap, and also pretty well tolerated for the most part. However, we do know there's some risk associated with it. So for instance, who might not be a good candidate for it? So pregnant patients, right, because it can affect what? The bones. Why? Why does it affect bones? Binds to calcium, right? Remember the food interaction it has? Can't take it with milk or iron or other metal products because you can end up having those being bound up and it prevents your tetracycline from beginning absorbed. So again, we know these things. We've talked about the tetracyclines previously. Be aware that also kids less than 8 years of age, probably not going to have a whole lot of acne at that point. But again, long-term therapy with this can cause what for those young kids? Discoloration of the teeth, right? Because again, it's binding to that calcium there. Other things potentially being used here include things like trimethoprim, sulfacetamide, which should say sulfamethoxazole. I have a typo on my own slides. Terrible. But so Bactrim might be an option here. Things like azithromycin, ciprofloxacin, all have been used as well. But majority of the time, tetracyclines tend to be sort of your go-to first-line agent there. Some other therapies have, and I promise I'll give you a break soon. I just want to kind of finish up this section here. We have things like salicylic acid. That's a cousin to what other drug we've talked about? Aspirin, absolutely right. So this has been used for a long time, but it's more of a sort of at-home sort of folk kind of remedy in a lot of cases. Limited studies to actually support its use over the other medications we already talked about. However, salicylic acid could also be used for what? Topical, So keratinolytic actually be used for warts potentially, right? So some patients will have, there's wart products. Obviously not going to be as effective as like cryotherapy and things like that, but that's something there. And we know what you can find at the hardware store that's good for wart treatment. I'll talk about duct tape a little bit later on. So duct tape can fix anything. And this is actually a medical issue that it can cause, or it can fix. Anyway, also we know salicylic acid can have some minor anti-inflammatory properties. So again, limited use in acne, there was something you may see. And then also it's interesting here, anti-androgen. So spironolactone, we've covered that drug before. Where have we seen that? It's a diuretic, right? Why does it work for, as an anti-androgen?
cause?
It's a partial androgen receptor agonist, right? Remember that? So it blocks the activity of aldosterone, but it's a partial androgen receptor agonist. So what you're going to find with anytime you're monkeying with the hormones, it depends on what the kind of the patient's baseline levels are. So if the patient has really high resting testosterone levels, this may be able to help bring that down a little bit in order to help mitigate some of those effects causing the acne, right? However, if you have patients with relatively low testosterone levels, this may be to bump it up a little bit. So I can see things like hirsutism in females because they have an increased overall testosterone effect from that. However, we do have some topical products that are available, and again, that provides better local action, right? Some patients will be on systemic therapy, though with spironolactone, just depends. And then oral contraceptives, right? So what comes in an oral contraceptive typically? Usually an estrogen and progesterone, right? So we'll talk much more about that, and there will be a gyne section next semester. This is useful in some women. You can tend to find, and actually when you look at the variety of, I mean, you guys thought we had a lot of drugs for antihypertensives, right? If you look at the actual birth control list, it is like yay big. There's a lot of different products that are out there. There's different progesterones, different dosing, different cycling, all kinds of different products are out there. Some people may have improved acne by getting put on some of these agents. Some patients may have worsened. It just depends on how they're going to respond to that. And so sometimes playing with a different product you're selecting can help with that. We'll talk much more about that next semester. So, and again, spironolactone, would that just be used for male patients with anti-androgen? No, you could use it for female patients. However, oral contraceptives, would you use that on male patients? You would not, right? It may sound silly, but you would not. I told you about one patient who called up and they said their son got into the birth control. I tell you about that. I was working at the Poison Center as part of my staffing for my fellowship. I was actually in the Poison Center, actually taking calls. And one guy that called up and he was extremely concerned. He was very concerned. You would think that like someone was actively dying. He said, "My son got into my wife's birth control. Is he going to turn into a girl?" Kid you not, this is the exact words out of his mouth. And so, first I mute, I get my laughs out, I unmute myself, and I get back to it, right? So obviously, I know your son's going to be fine, but if he wants to go shopping over the next couple of days, just indulge him, please, just let him. He didn't get it. He was like, "What?" I was just like, "I'm just kidding, he'll be fine." Some people aren't ready for jokes when they're in the midst of a crisis, right? Anyway. There's some weird people out there. Right? Not everyone has medical knowledge. Anyway, so some other things we can use potentially for acne. If you have particularly inflammatory-based acne, would you get these really big inflammatory nodules? Actually, intralesional steroids can be useful here based off its anti-inflammatory activity. So that can be really beneficial. However, you're more likely to see systemic absorption there, so that is one concern. Certainly, if you're using it more chronically, you do worry about things like skin atrophy happening, adrenal suppression, etc. Right? And we mentioned that oral corticosteroids could also be used usually for short course sort of flare-ups or exacerbations here. Again, typically just a couple days worth of therapy, get them under control, the inflammation under control, and then get them back to baseline. But things like prednisone, dexamethasone, all can be beneficial there. Okay. Again, doesn't make sense because you're like, well, wait a second, you said steroids can cause acne, but again, depending on the pathophys, if it's really more inflammatory based, this may be a good option for those short courses, right? So typically you're going to be working through a stepwise approach, so very similar to what we talked about with asthma. I can ask questions, say, hey, starting out, patients coming in and they are already on this regimen, what would be something to add on to it, right? Or what would be something to switch this patient to? Or what might the patient be contraindicated from receiving, right? So for instance, if the patient comes in and they are 3 months pregnant, this is not going to be a good option for them. Accutane, any of the retinoids, not going to be a good option for them, right? If they came in and they were already taking, say, benzoyl peroxide, it's limited just to the face, and they want to see what you can do for them. What might you put on? No other contraindications. Yeah, maybe a topical retinoid would be a really good option there. So you can kind of work through this and kind of see how things are working. Typically, you're going to find that for more minor cases here, again, where it's more sort of localized, topical retinoid can be a good drug of choice because they probably tried benzoyl peroxide. We may add a topical retinoid on top of that, right? And then see how they progress. Again, obviously, if you can try to scale down on the concentrations, that is going to help mitigate some of those side effects. So always try to do that when you can. Moving and stepping on up, though, looking at things like topical retinoids plus benzoyl peroxide, also starting to look at topical antibiotics, right? See, that might be a good option to include some, clindamycin or erythromycin, something like that. If that's not working, then you can step it up and then think about things like systemic antibiotics, right? The more diffuse the disease is, also you want to think more about systemic therapy as well. So kind of where it's localized to is going to be important. Obviously, those are not working. Also consider the systemic retinoids, right? So I'd probably try the antibiotics prior to going to the isotretinoin, but it just depends on the patient, depends on contraindications, past medical history, et cetera, right? These are all things you want to kind of think about in terms of this stepwise approach there, right? And again, think about a patient who's going to be going on Accutane, a female patient. She's probably also going to be put on what else? Birth control as well, so which may be beneficial, which may be harmful depending on the situation, right? So sometimes you have to switch those up a little bit, try to find out what's going to work for them based on the progesterone that's in it, based on the dose of estrogen, etc., right? So any questions on that? All right, so kind of work that chart, kind of get a feel for how we do that. If no other questions, then we'll do a 10-minute break and come back and continue on. All right, let's get back to it. So I had a couple questions up on the board, one of which, are there any benefits or issues with the bupropion in Parkinson's patients? Now, why would someone ask that question, do you think? So what's the main pathophysiologic cause of Parkinson's? Lack of dopamine, right? The dopaminergic neurons basically kind of peter out, and they have that relative lack causing movement disorders, etc. So the question is, would there be any issues with using bupropion or maybe benefits by helping to re-regulate that dopamine? What do you guys think? None that I'm aware of, so it doesn't mean there's nothing out there, but certainly nothing I'm aware of. Keep in mind for these patients, a lot of times it's not an issue of them, frequently it's a problem of them actually losing the function of those dopaminergic neurons. They can't just release it anymore, they can't even produce it from those neurons, so frequently have to give a replacement. So you ever heard of Sinemet or levodopa, carbidopa?
Yes.
Heard of that? That's the kind of the cornerstone of therapy for Parkinson's, is actually giving a replacement for that dopamine they can't produce anymore. However, there are some medications that we actually use to try to help extend the life of the dopamine that they can produce. So sometimes we'll give medications early on for that. I don't know if bupropion's ever been investigated for that, so it's a good question. Perhaps you could do some research and come back and report out to us. Another question came up here. Not clear on benzoyl peroxide and activating tretinoin. They provide this link here, which I clicked on. It was a risky click, but it looked like a reputable site, so I said I'll go with it. And so I was told by Jerome I shouted, it does not. Any comments? Let's look at what we came up with. So we'll do an impromptu 30-second journal club here. So
in preparation,
womp womp, you guys get stuck with more EpiBio. Okay, so this is a 2010 article come from the Journal of Clinical and Aesthetic Dermatology. Now, does anyone know if this is a good journal in dermatology? I don't know either. Again, this is not my area of expertise, so I would not know if this is a good reputable journal or not. Let's assume it is, right, for our purposes. And again, I'll do a fallacy that I tell you to never do, and I just read the abstract, so I can at least give you the brief synopsis. However, they were looking at actually combining tretinoin plus benzoyl peroxide, and look at the concentrations. They seem pretty reasonable, typical, 0.05% tretinoin plus benzoyl peroxide. They actually get it down to basically mix them together to get 5% benzoyl peroxide. But also there's clindamycin in the mix as well. So what could the effect of clindamycin be in this study? We call that. And that's an outside variable causing confounding, right? So we don't know what is the effect of clindamycin on here. Maybe that's having some effect. We don't know, right? So anyway, so they basically mixed the two together and then measured concentrations of tretinoin over the course of like 7 hours or so. And what do they find? Basically, tretinoin had no appreciable decrease in concentrations. So what does that tell us?
still active.
Still active, right? So perhaps maybe the old dogma of benzoyl peroxide deactivating tretinoin, maybe it's dogma, right? Maybe it's one of those things that we just said for years and years, and that we've never had any good actual clinical evidence to back us up. I mean, would that ever happen in medicine? All the time. There's so many things we do that we actually have no good evidence for. We just have been doing it for decades, and we're just going to continue doing it on. So anyway, anyone know what the average turnaround time is from the time the article gets published to when it actually gets like changing clinical practice, actually taught to students down the road? It's like 17 years on average for actual practice changes to occur. It is an extremely long period of time because think about this gets published here and maybe gets cited a few times and eventually gets put into a book chapter, and eventually a school will adopt that book chapter, and then eventually they teach it to PAs who eventually go on and then teach it to their students. You see, it takes a long time to propagate this sort of stuff out. So perhaps this is one of those bits of information that if I'm, God willing, still teaching in 10 years to PA students, if you haven't ousted me by that time, maybe this will be what we teach. Maybe that'll be in all the textbooks to say, hey, actually, this is not a problem anymore. So who could say, right? But if you go to work in dermatology, maybe you'll say, hey, actually, I have a study that says that you can combine these two together and it's no problem. So there you go, right? That's more than 30 seconds, but oh well. Anyway, but if you were really interested in derm, what would you do with that article? You read the whole thing, right? You go through, make sure their study methods are all valid, make sure all the p-values look appropriate and all the odds ratios and all that good stuff, right? Anywho, so getting into dermatitis, right? So now we're going to be focusing more on specific inflammation of the skin itself. We know this is a very common sort of presentation for a lot of patients, especially if they have other allergic conditions like asthma, especially. You can see a lot of patients with eczema and allergy kind of as concomitant disease states there. And we're going to see that the skin barrier dysfunction plays a big role with this. And, in terms of like clinical presentation, there's a lot of major and minor sort of indicators here. I'm not going to get specifically high into this or into like diagnosis and things like that because you get that in your medicine courses. But certainly we'll see that inflammation is a big product here because we were seeing that things like increased serum IgE, right? There's obviously something that they're reacting to, causing this inflammation, causing the skin to react in such a way. So again, sometimes trigger avoidance is going to be a big way to prevent a lot of these things. Sometimes targeting pathways of inflammation are going to be another major role for pharmacologic therapy, as we'll see here in just a little bit. So what's our goals of therapy here? Obviously provide some symptomatic relief for the patients to alleviate a lot of the itching and inflammation there in the skin. If we can identify any of those triggers, it's obviously going to be beneficial to try to remove those. And then obviously if we can try to prevent any exacerbations, kind of keep things under control, and prevent any secondary skin infections. Now, why do you think they get secondary skin infections? Itching and they're scratching and it gets inflamed and you open up some of the skin there and then so you can see infection. So trying to prevent that is going to be beneficial. So certainly a lot of non-pharmacologic therapy we can recommend for our patients. Certainly keeping the skin nice and moisturized is going to be beneficial here. So for instance, avoiding any kind of like really drying solutions, alcohol-based solutions can be beneficial. Applying lubricants after baths, things like emollients and things like your aquaphors and Eusoderms and things like that are beneficial because they help keep the skin hydrated, prevent it from drying out and getting really itchy there. In some cases, we'll use antihistamines to help reduce some of that nighttime itching, right? So again, if they are asleep and they're sitting there and they're not even conscious of them scratching and things like that, that can be beneficial. So what kind of sedating antihistamines might you recommend? Benadryl. What's another name for Benadryl? Diphenhydramine. What else could we recommend? Hydroxyzine potentially, right? What else? Doxylamine another good over-the-counter one. Chlorpheniramine. A lot of first-generation antihistamines that can be useful, right? Because again, they're sedating, so the patient will be asleep, helps with the itching anyway with the antihistamine effect. Kind of get two birds with one stone from that standpoint. That can be good. Also doing things like distracting children. Actually, I had my oldest one, Lily, she had a scratch on her leg that had like bled at some point, scabbed over, and then got a little irritated to get itching. So what does she do? She tries to scratch it, right? So then it looks like a murder scene at my house because there's like blood on the couch, and I'm like, what happened here? And it's because she kept scratching it. And so I'd say, hey, stop scratching your leg, and she'd look at me and say. So when they learn how to spite you, it can be a challenge. So learning how to distract her from doing that sorts of things is a challenge, but that can be useful, right? So anyway, getting into the pharmacologic therapy, topical steroids are going to be sort of the gold standard here. We'll talk about the different varieties here. And again, I'm not going to ask you, now when you covered derm, have we talked about steroids yet? Yes, okay, thank you. Thank you for being honest, some of you. So there's different classifications in terms of the potency of steroids, right? Now, I'm not going to get so granular to ask you on a test question, is this one super potency or moderate potency? I'm not going to get that granular with it, but the concepts behind these are what I want you to know in terms of like what may make something higher potency, what could be the outcome of using a higher or lower potency steroid, what are sort of the clinical implications thereof, okay? So those are the things I want you to know. So anyway, so the choice of agent was going to depend on the severity of disease, the site of the disease itself, so where is it localized to? So thinner skin, obviously we may pick a different type of steroid than if it's an area of thicker skin, as the case may be. Usually for low potency steroids, we'll talk about some of the common ones, it's going to be suitable for the face, detritus areas, infants, because infant skin is typically pretty thin, right? This is better for long-term therapy. The goal is generally to get down to the lowest potency steroid that you can in order to help maintain their symptoms, right? That lowest potency maintenance therapy as you can. For medium potency, you can use for more general body application there. And usually for exacerbation, then you kind of bump it up. So if they have a flare-up, then you go to, say, medium or high potency steroid, get that things under control in terms of inflammation, and then you scale it back again, okay? Usually for a week or two, and then you go back down to a lower potency if you can, right? Scale it back as best you can. Now, adverse reactions to our steroids, you can find some local reactions, certainly. So what are some local effects you can see from topical steroids? So skin thinning, like dermal atrophy tends to be one of the more common ones you're going to run into. Certainly worsening acne in the area where it's applied, rosacea, things like that. Even the drug itself may cause some degree of dermatitis, right? A lot of times that can be related to the vehicle that's actually being put in, whether it's a cream or an ointment or gel, things like that. The systemic effects are certainly where I'm more concerned with in the long term, right? Especially when you're getting into more of these higher potency steroids. So for instance, what do you think happens to their blood sugar? It's probably going to go up, right? How about their blood pressure? Probably going to go up, right? Certainly, how about effects on their immune system? It's going to be decreased, right? So again, some immunosuppressants. How about effects on the bone? Can worsen osteoporosis, right? So all these things you're going to see with more chronic application of these corticosteroids, more likely to see it depending on where it's applied. So for instance, if you apply it to areas of thin skin, more likely to see absorption. Depending on the occlusion of the vehicle you're picking, so if it's an ointment, is going to be more occlusive than a cream, which is more occlusive than a lotion, right? Better staying powers. It's going to be having more contact time there. And then also the potency itself, right? And also we're going to see that the actual salt form of the steroid can also play a role here as well. And I'll show you some examples of that in a moment. And certainly, especially for little kids, we're also worried about things like adrenal suppression. So again, if they're on like a high potency steroid for a long period of time, you may need to wean them down gradually, and you would not want to stop all of a sudden, right? Okay, so here's a good chart. You can look up some the different steroids. I have some listed here as well, so we'll kind of go through that. But you can see that depending on the agent you're dealing with, they kind of range anywhere from, say, the more mild, low potency steroids all the way up to the very potent. Depending on the chart you look at, they'll have different classifications of them, which is, again, why I don't get super granular and asking you which one of these is classified as potent versus moderate, because it just gets a little murky there depending on the resource you're using. But the things I want to kind of point out is, one, in general, hydrocortisone is going to be the wimpiest out of the bunch here, okay? So generally in hydrocortisone, where can you get that? Over the counter, right? You can go buy that from any store you go to. So again, limited side effects because it is such a low potency steroid. Typically the concentration you're getting over the counter as well are going to be minimal in terms of its systemic potential. Now again, I should change my mind. Just go ahead and memorize the slide. You'll be fine. I'm just kidding. No. So some of the things I want to point out, though, are going to be some of the things in terms of their formulations and the concentrations, and sometimes that can delineate which classification it gets put into. So, for instance, if you're looking at, say, a cream versus an ointment, which one do you think would bump it up into a higher potency? An ointment, right? Because it has better staying power. So you're going to see that is going to have more systemic effects because it has longer contact time, better absorption, right? Sometimes you'll find, I think on the next slide, this will be more apparent. So for instance, looking at hydrocortisone, you know, certainly the least potent, but then this is just base hydrocortisone, right? Depending on the salt form that you put it in. So for instance here, hydrocortisone butyrate or valerate actually gets up into a higher potency, right? So the salt form can have an effect on it as well, increasing that potency there, okay? Concentration is also going to be another big one as well. So again, as you increase the concentration, obviously the potency is going to go up as well, because again, more of it's able to cross over because you're changing that concentration gradient, right? The bigger the gradient, the more absorption you're going to get with that, okay? And again, tailor it to what the patient needs in terms of, you know, is an ointment, do they need the better sort of occlusiveness? Are they looking for something that's going to wash off better? Maybe a lotion might be more preferential for them. You know, things like that are all going to be influencing which ones you're going to be picking, right? And again, the chance of using every single one of these in your practice if you're working in derm is probably unlikely, right? So you probably get used to a certain stable of medication to use day in and day out, and that's just what you use and that's just what you know, right? But it can be listed here for completeness' sake. What are some other things we could do for dermatitis outside of the steroids? Well, we have other topical immunomodulators as well. Now, immunomodulator, what do you think that means? Modulates The immune system, for sure. Anytime you hear someone says, I think this modulates this system, that usually means we don't know what it actually does. In this case here, though, we're actually modulating the immune system down, right? So we're trying to help to decrease inflammation. And so we have things like tacrolimus and pimecrolimus are going to be two common ones you can see used here. These are good for patients in whom steroids might not be a good option, or maybe if you need some additional benefit, maybe add this on board. Now, has anyone ever heard of tacrolimus before? Ever seen it used for any other conditions? We actually use it for transplant, or potentially for autoimmune diseases and things like that. It's really good at helping to prevent, specifically in transplant, to prevent the body from rejecting foreign tissue, like a transplanted organ and things like that. So we're kind of doing the same thing here, just applying it directly to the skin to decrease the inflammation. So this will help to reduce the extent and severity of those symptoms there. However, you may notice some other side effects that are not going to be shared with the corticosteroids. So for instance, there may be some possible cancer risk, right? So by minimizing how often you're using this and the time you're using this, that can help to reduce that risk there. And again, you would not want to use this in someone with an already weakened immune system, because you could see some systemic activity and worsen that immune system as well. So secondary infections would be something you want to be aware of. These tend to be pretty irritating on the skin, and definitely recommend, due to the photosensitivity that can be induced by these, use high SPF sunscreen, right, in order to make sure that they do not develop any sort of sunburns, even for just normal walking outside, things like that, right. Other things we could do, we could certainly use oral corticosteroids. These are going to be better for those flare-ups when you have to really kind of get things under control. They typically be a little bit quicker in terms of its action there, but then you would want to have the patient taper off of it slowly in order to prevent sort of a flare-up of that inflammation. So that'd be one thing you want to note with that. But certainly any of the ones we've already talked about would be good options here. So dexamethasone, prednisone, etc. Right? So any questions on this inflammation or anti-inflammatories? Essentially, yeah. Yeah, it's kind of just another term for them. I guess immunomodulator could also apply to things that sort of like ramp up the immune system. There's a couple cancer drugs that do that. But yeah, specifically these are going to be helping to tamp down the immune system, for sure. All right, so let's look at a couple topical antibiotics you may use for your patients here. So some of these are going to be typical run-of-the-mill, sort of like, for your cuts and scrapes and things like that we use pretty commonly, especially like ERs, urgent cares, etc. So first off, we have bacitracin, and so this is going to be one used very, very commonly, has a very good broad spectrum activity. And what's the benefit of using a topical antibiotic? Less side effects, no systemic side effects. Also, what about the actual activity against the bacteria? Pretty good, because you can get really high concentrations there, right? So if you have a laceration, apply some bacitracin on there. Shouldn't really see a whole lot of systemic effects, really none. And then you get really high concentration, so it's hard to develop resistance against drugs like this, right? So again, this one's going to be good because applying topically, what kind of bugs typically grow on the skin? Staph, strep, a lot of different gram-positives, right? Pretty broad in terms of that. Also, it can get things like anaerobes, right? Why do we care about anaerobes? In terms of like cuts and scrapes and things like that. Well, they tend to grow in the soil, right? So you typically find a lot of anaerobes grow in the soil. That's why it's a concern, especially after like traumas. Like if you had someone who was like in a motorcycle accident, was drug along the ground, like you worry about anaerobic infections there. This is another case where using something like bacitracin is good because it kind of covers everything essentially. So you may see it used in combination with other topical antibiotics. So for instance, if you ever see something called like double antibiotic, it's usually this plus something like neomycin or polymyxin B. And if you ever see triple antibiotic ointment, it's usually a combination of bacitracin, polymyxin B, and neomycin. Okay. Now we've seen some of these drugs before as well. Where have you seen these come up? For ENT stuff, right? We talked about them being used in the ear for things like otitis externa. And so remember, there are some concerns with those, as we'll see in just a few moments here. Again, nice thing is that they have very limited side effects. You may see some local dermatitis. A lot of times it's related to the vehicle that it's in, more so than the drug itself. Mupircin's another one you'll see frequently used, and this has a very specific purpose. This is actually used to prevent the growth of MRSA in patients who are carriers for it. So for instance, if a patient comes in to the hospital, they'll do a nasal swab to see if they are carriers for MRSA. If they are, they test positive, then we actually will apply Bactroban around the nares, and that will help to eliminate that carriage of MRSA. So it's a very specific sort of use for this medication here. So you may find a lot of hospitalized patients who will be on this for a short course. Again, another nice one because it does not get absorbed systemically. However, because of the vehicle that it's in, you couldn't actually, again, you're applying it to the nares, so there's some of that mucosal tissue. You can see some irritation there due to the actual vehicle that it's in. So just wanted to note with that. I mentioned polymyxin B frequently seen in combination with things like bacitracin. This one you want to be somewhat careful of, especially with large wounds. If you're applying a lot of this to areas of, like, say, denuded skin or things like that, mainly because we do know that polymyxins can cause neuro and ototoxicity. This is rare, though, if you're using it for typical cuts and scrapes and things like that. It would be a rare instance. If you're working like in a trauma unit and you had a large area you're actually working with, or say wound care or something like that. But again, really good activity against a lot of gram-negatives. Aminoglycosides are also used occasionally, like neomycin is a pretty common one. What do we say about neomycin in terms of its use in ENT? What is it likely to cause? Dermatitis, right? Or in this case here, we're going to see that allergic reactions are more common to neomycin than polymyxin B or bacitracin. So you do want to be careful because it can cause sensitization, can cause dermatitis for those patients there. So neomycin, the most common one out of that bunch. And so again, if a patient had a reaction to triple antibiotic therapy, then you could just scale it back, just use either bacitracin alone or maybe use a double antibiotic. A couple topical antifungals that we may be using for our patients here. Things like clotrimazole, ketoconazole, etc. Again, they're working to help production or block production of that fungal cell wall by inhibiting that CYP450 here. Now, I mentioned with systemic fungals, antifungal drugs that block CYP450 for those fungal cells. We also saw a lot of drug interactions there, but for these topical ones, do we have to worry about that? Nope, we really don't, because again, no systemic absorption, which is beneficial. Again, sometimes you'll see these being used in addition to corticosteroids at the same time to get sort of rapid relief of symptoms, itching and pruritus, things like that. And then you'll find that the antifungal can take some time to kick in. Remember, fungal treatment times typically a lot longer than, say, for bacterial causes. So say like 2 to 3 weeks for instead of, say, 7 to 10 days for a typical antibiotic regimen. Other things you may see include things like cyclopirox or Pinlax. This is actually a lacquer you'd apply to the nails to treat those patients with, say, like a dermatomycosis or candidiasis, things like that. However, typically when you're dealing with, especially like toenail fungus and fingernail fungus, things like that, they tend to have a long treatment duration because it's very slow growing, and so typically you have to be applying this for, say, months. And oftentimes you'll find that the drug itself is not that ineffective. It's the fact that compliance is poor with these medications, which is why a lot of patients end up failing therapy there. Okay. We see things like the alloamines, like naphthene and terbinafine, again, typically applied topically, athlete's foot, things like that can be useful here. Again, compliance is going to be the big thing. Make sure they're using it for the full course, otherwise the infection is going to come right back for a lot of them. Some other antifungals, things like nystatin can be used. Actually, we use a lot of nystatin for patients with G-tubes in place because we'll actually be able to apply it around the area. Sometimes we'll have a little growth of candida around the G-tube site, and so we can actually apply nystatin directly around there in order to help eradicate that. So it's one thing you may see in the hospital potentially. But again, nice thing, no systemic absorption, no big side effects to worry about besides some local skin irritation. We have a couple topical antivirals you may run into as well. So for instance, we have acyclovir. Anyone remember how the antiviral drugs we talked about work? Yeah, they inhibit the viral DNA replication. Basically, they kind of substitute in for a guanine, and then they're chain terminators, so you can't add on any other additional nucleotides to that. Again, this is useful for things like herpes simplex virus. If you have cold sores, things like that can be treated with this. It helps to, will it eradicate the infection? No, but it can help to limit the duration and severity of the illness there, so it can help to sort of shorten that up for a period of time. Again, local irritation, not going to see a ton of side effects because, again, it's used topically, not a lot of absorption. This one's kind of interesting. This is actually called imiquimod or Aldera. This is actually used for warts, and actually what it's going to be doing, this is another immunomodulator, but instead of suppressing the inflammatory system, this actually will help to ramp it up, and so it actually stimulates release of things like interferon alpha and TNF to actually attack the viruses actually causing the warts there. And so what's interesting is that the more irritation that you have, the better the drug is working, right? So may not be tolerable by your patient depending on how severe the effect is, but again, it's going to help to get rid of those warts, and then hopefully there'll be a limited duration of use there. Yeah. So any questions? I know it's kind of quick, but it's just kind of miscellaneous sort of drugs you may run into occasionally from a derm perspective. Any questions on that? Okay, I do have some more time left, so I'm actually going to start the next section in order to make sure that we have enough time for a review prior to the test. I imagine most of you would want to review before the test, right? Yes, I'll take that as yes. So let's go ahead and look at the oncology section. I'll kind of get through the very basics here just to start with, and then we can really hit the drugs in earnest the next time we meet. Okay. So oncology. This is another thing that I'm not a particular fan of. I like to give antidotes to patients and save them when they're being poisoned. What is oncology drugs normally doing? They're directly poisoning the patient. So not my favorite modality of treatment, however, quite necessary. And I get to deal with this like day in and day out when I'm working clinically. You know, we have a lot of kids with different leukemias and glioblastomas and rhabdomyosarcomas, all kinds of different cancers that we get to treat. And it's really like kind of interesting in kids especially too, because they tend to respond a lot better in many cases than adults might. Because again, they're just healthier in general, and so it's really gratifying to see a lot of these kids actually achieving remission of their cancers. But we're going to find that the drugs themselves are quite nasty in terms of the side effects they're going to experience, in terms of needing a lot of supportive care. We'll kind of go into all those different points. Anyway, so what is cancer? Besides your sign, perhaps. It is abnormal cell growth, right? So basically, normally your cells will get the hint at some point they need to stop growing, right? So you just don't keep growing cells after cell after cell. Eventually things like contact inhibition will prevent cells from growing. Cells will trigger off apoptosis when they're not really needed anymore, right? What happens here though is you lose some of those factors, right? So the cells don't ever get the signal to turn off reproduction, and they just keep undergoing mitosis, and eventually it can lead to cancer, right? And so there's a lot of reasons why patients may develop cancer. Certainly exposure to carcinogens can be a big one. So for instance, you know, smoking can lead to, has an influence on lung cancer, right? So different types can have very specific effects. Medications can potentially lead to different types of cancers. Just like we talked about, any of the antiarrhythmics can cause arrhythmias. Cancer medications can also cause secondary cancers, right? And again, it may seem counterintuitive, but it's one of those risks that we have to take in addition to the potential benefits of eradicating that original cancer, right? So anyway, what we're going to find is that typically there's some sort of initiating sort of factor there, which may be produced by carcinogen or a mutation in the patient's genes, etc. And basically what you're going to find is it's going to provide selective growth to some of those clonal cells, right? So basically they're going to be able to, say, turn off maybe that contact inhibition, so that even though they're surrounded by other cells of the same type, they'll just kind of continue growing. And again, how many cells does it take to start a tumor, right? Just one cell, right? And it divides and divides and divides. So again, and it can be really difficult to get rid of every single one of those cells to prevent that cancer from returning. It then undergoes some sort of promotion sort of stage there, where things like, you know, diet, environmental exposures can help to influence this, as you'll see, and then eventually it progresses on into full-blown cancer, right, where it can metastasize, spread around, whatever the case may be. So looking at some known carcinogens, and again, this is not a list I want you to memorize, it's just to give you some examples of things that we can find or different drug-induced causes of cancer. So for instance, when I say anabolic steroids, what does that mean? What do you think of? Things like testosterone, right, or other derivatives, other androgens that will stimulate those testosterone receptors can lead to things like liver cancer. We can see things like anti-estrogens, something that we can use to treat certain types of breast cancer, can actually lead to endometrial cancer. Again, trading one bad thing for another bad thing, but again, it's about mitigating risk. It's about looking at the potential benefits, right? Looking at things like, let's see, well, these are just other cancer drugs like the epidophylotoxins, but immunosuppressive drugs are another big one. So if you have patients who are, say, a recipient of an organ, right, and you're giving them these immunosuppressants, and then they get a secondary lymphoma after that, again, these are unintended consequences, but known risk for these medications. So anyway, so what are the kind of the different functional capabilities of these cells that provide them the ability to kind of continue this rapid growth? Well, basically they're doing a lot of things like evading growth suppressors, right? So different hormones or chemicals that would normally suppress their growth, they're evading that. You know, they have this enabling replicative immortality, where basically they can just continue growing sort of ad infinitum until they basically take over the entire body, essentially. You know, inducing angiogenesis, what does that mean? increasing the blood supply, right? That's frequently was something that is going to lead to a limitation or sort of a plateau effect of these cancerous tumors and things like that, because if they have a limited blood flow, they have limited nutrient supply, they may eventually outstrip themselves. That may be the rate limiting factor for some of their growth there, right? That affects different types of cancers more depending on the type you're dealing with there. And then they're just really resistant to cell death. Normal triggers that would say, hey, you should probably undergo apoptosis, right? That programmed cell death, they lose that ability to do that. And so in these cases, we're going to find that some of our drugs may be working on different pathways here in order to try to get rid of these cells, and we'll look at the different mechanisms in a few moments. So, and again, normally some of these growth of cells is a normal thing, right? So hyperplasia, for instance, if you are stimulating these cells, eventually they may increase in the number, but this is a reversible sort of function here. So kind of think like a callus or something that forms on the skin, right? Hypertrophy totally, or hyperplasia, totally normal sort of process. Problem though is when we end up running into this metaplasia where you start to have these adaptive substitutions of different cell types, usually due to things like chronic irritation, so kind of things like smoking, causing esophageal cancer, things like that. Normally you're going to find loss of these functions here, these cells, when this sort of occurs. When this dysplasia happens, you're going to lose some of that uniformity, some of that architectural orientation. This still may be reversible in a lot of cases there, so again, we're not really at the danger point just yet. But once we get into the neoplasia, this is where we start to run amok, right? So this is where you have this uncoordinated growth that's going to continue growing without any other sort of responses there. And you're going to see this P53 gene is going to be downregulated. That's one of those things that helps to trigger off apoptosis. They have this immortalization. Anyone ever heard of a telomerase? What does that do normally? Kind of like chopping off like the end of the DNA, so eventually it's there's going to be a point where it can't really replicate anymore. You kind of lose that enzyme such that the cells can just continue growing. So we have that immortalization that actually happens there. And again, once this occurs, this is the irreversible sort of stage. This is where we need to come in and do something about that. So again, you can consider them to be benign. They can be malignant, right? So depending on whether they're nice and localized and they're encapsulated, a fibrous capsule that prevents them from spreading. Obviously, we're more worried about the malignant types. They're going to be spreading around, potentially causing metastases in the body, etc. And again, how you grade them is going to be based off the type of tissue you're dealing with, how much of its function it's lost or changed, if it's spreading around. I'm not going to ask you specific questions on grading this type of tumor. You'll get that certainly in your medicine courses. But again, obviously, the higher the grade, the worse off it is for your patient, right? So getting into the principles of therapy, this is the thing I want to spend most of my time on, at least in my remaining few minutes here. All it takes is one single clonogenic cell in order to provide for this unlimited replication. So you have to kill every single cell in order to get rid of that cancer. So for instance, if you have a brain tumor and you have a surgeon go in and cut it out, have they got every single cell there? You'd hope so. Could there be some left over? At least one cell? Probably, right? So this is why you're going to see that we oftentimes will involve different modalities of therapy. You may get surgery and then radiation, or radiation and then chemotherapy, or combining these two together, or at least two or three of these together, or you're going to get better cell kill rates in order to get hopefully every single one of those cells there. And again, depending on the different types of tumors, you're going to find that they have different growth patterns. And this is important because depending on where they're at in their growth cycle, this is where the different medications can fit in. And so in general, our chemotherapeutic drugs are going to be affecting fast dividing cells the most. Okay, any cell that's actively undergoing mitosis, those are the cells that cancer drugs are going to be working on. Okay, so for instance, what are some fast-growing cells in your body? Say right now, the hair, right? So what's a frequent side effect of chemotherapy? Alopecia, right? What other cells? Skin cells, right? So in specifically like GI cells, I think like GI epithelia. So you can see things like stomatitis develop in the mouth, right? You can have diarrhea associated with killing off those rapidly dividing GI cells, right? You have malabsorption of nutrients. What else? What's in your bones? The marrow, right? So actually the ability to produce new blood cells is going to be suppressed, right? So what does that do to your white cell count? It's going to drop, right? So again, you find these patients are going to develop neutropenia, and that puts them at risk for what? Infection, and that's oftentimes what actually kills these patients. It's not the cancer itself, it's usually the secondary infections that develop along the way. So these are the problems you run into, and this is why rapidly dividing cells are frequently your cancer cells, and those are going to be the ones that we're trying to target there. So, and again, why are antibiotics better than our cancer drugs? Well, because antibiotics are focused on specific bacterial targets. Here, what are our targets? just our normal cells, right? So again, we're hoping to target the cancerous cells, but you're going to see there's a lot of casualties there, right? Especially with our traditional sort of chemotherapy. And so again, depending on how it's fast growing, slow growing, so say for instance like leukemia, very fast growing sort of tumor, that you're going to see that has very sensitive to the effects of chemotherapy. Some slower acting ones like colon and prostate cancer may not so much, right? Looking at the heterogeneity of the tumor, sometimes multiple cell types can increase the resistance to things like our chemotherapy. And so there's this concept called Gompertzian cell growth. You guys ever heard of that? You haven't started your cancer stuff in CMS yet, right? Yes, okay. Basically, this means that every tumor takes a constant time to double its size. But again, that's going to be on this sort of exponential sort of growth pattern here. And again, that growth fraction, as the tumor size increases, your growth fraction will decrease. What do you think that is? So I'll show you a graph in a second, but basically you'll find this plateau effect occurs mainly because you're outgrowing your nutrient supply. So this is where the angiogenesis is really important for those tumors to continue growth. Eventually they're just going to run out of building blocks essentially to keep undergoing mitosis. And so you can see here, this is what the cell pattern growth would look like, right? A constant doubling size. You see here the number of cells in terms of powers of 10, right? So you can see here this is going to have a pretty constant sort of growth here. And again, imagine, say I were to kill 99.9% of the cancer cells. I were to get rid of them with, say, surgery, right? So say I have a diagnosis of the patient and I have, say, a 99.9% reduction in the number of cells left. Well, guess what? I still have lots over. That's still a lot of cells, right? And so this is why you typically will see different modalities being used together in order to try to get rid of a big chunk of cells at once, and then you give them follow-up therapy to try to get rid of the rest of them as time goes on, okay? But again, as soon as you reduce that number of cells, guess what happens to the growth supply, or the nutrient supply for that tumor? It's really good again because they got rid of all the other cells, so now they can start to grow more rapidly, right? So you're going to see that can affect what percentage of those cells are in a rapid sort of growth phase. And again, looking at the actual size of the tumor based on how many cells it has, you can see here that quite a few cells make up, say like a 1 kilogram tumor, right? It's how many pounds? 2.2 pounds. That's a pretty heavy tumor, right? And so what you're going to see is that typically, especially if a well-localized tumor, this is removal is going to be the first thing you want to do there. So where surgery can be really useful here. Radiation may also be useful if it's, say, not a very easily removed tumor, depending on where it's at. And then what we're going to find is that chemotherapy is used typically as a follow-up, right? So kind of working as cleanup there to get any residual cells that are left. You typically find, though, that chemotherapy is going to increase the chances against those metastatic cells, but again, it can also induce those metastatic changes in other cell types, right? Now again, does any type of surgery cause cancer? Well, no, but certainly all of our chemotherapy drugs certainly can. So this is why we use these multiple modalities. And again, here, just to kind of reiterate that, again, get the diagnosis, use surgery to get rid of that tumor, and then we follow up with rounds of chemotherapy. Now you notice here, why do you think we use cycles of chemotherapy? Why do we stop and give the cells time to replenish? Because you got to give the normal cells time to recuperate as well, right? You can't just keep giving more and more chemotherapy just to drive that all the way down because the patient would be dead, right? This is poison we're giving to the patients essentially. So this is why it's really important that you'll see that chemotherapy typically goes in cycles, right? I'll show you an example of what a roadmap looks like a little bit later on to talk about a chemotherapy regimen. So, and again, our drug concentrations, the exposure times, all of this, the frequency of administration, it's critical. And this is why you can see that these patients will undergo very specific regimens for their specific type of cancer, right? Based on the grade of it, based on a lot of different factors there. And again, the benefit here is that we're going to try to maximize as much benefit in terms of killing off those cells while trying to mitigate that risk they're going to develop there. But we do know we're going to cause significant side effects. And myelosuppression is oftentimes the most fatal one of those. Because again, we're suppressing growth of those blood cells, and thus secondary infections are going to occur. Okay, I'm going to go ahead and stop it there. If you guys have any questions, I'm going to leave it on like a cliffhanger so we can talk more about the different principles of therapy. Let me see if there's any questions on the board. Okay, let's see. For combination antifungal corticosteroid topicals, if steroids feed fungus, could the corticosteroid element of the combo drug potentially worsen a fungal infection? That's a good question, right? So again, this is typically on the very short course terms of things. The steroids are going to be used just to get the inflammation down, so that way the antifungal can kind of kick in. So traditionally speaking, the antifungal is going to be able to kind of keep that in check, such that you're not really worried about secondary infections due to that, at least as far as I know. Maybe there might be some circumstances where that's not the case, but typically that's how we kind of go about it. So, any other questions? If not, I will let you talk to Professor Kaplan for a couple hours and then come right back to me. All comes full circle.